the organizing committee for the invitation, and it gives me a great pleasure to share with you the journey of heart transplantation at King Faisal Specialist Hospital. As you know, the first heart transplant, it has been 5 decades since the first heart transplant was performed in 1967 by Christian Bernard. Over the last 5 decades, there has been considerable improvement in the outcome with the refinement of donor and recipient selection, refinement of the technique, and the improvement in immunosuppression. And this persisted despite the increasing complexity of patients that undergo heart transplantation. In the Kingdom of Saudi Arabia, the first heart transplant, as you heard from Dr. Ghanem, was performed in 1986 in the Prince Sultan Cardiac Center in Riyadh. The first heart transplant was performed at King Faisal Specialist Hospital in 1989. The beginning was slow. We had a slow start. The team experience was quite limited. We had limited resources. In 2005, major re-engineering of the program was done. We re-engineered the process of evaluation, candidate teaching, monitoring, and follow-up care as well. And most importantly, we had a dedicated team for heart transplantation. We also joined the ISHLT, and we are members now of the ISHLT. This is a team which it's a multidisciplinary team from different departments, and every member of that team is as important. That resulted in a 5-fold increase in the number of heart transplants when you compare 1989 to 2004, compared to 2005 to 2017. As I mentioned, the beginning, we had a slow start. We were doing small number of patients, between 2 and up to 7, and it wasn't until 2005 when the program started to pick up again, and we peaked last year at 35 heart transplants. Out of that, we did 9 pediatric heart transplants, which puts the pediatric heart transplant as a medium-sized program. Now, if you compare us with the rest of according to the last ISHLT report, you will find King Faisal belongs to this group, which puts us in the top 10 to 15% of centers worldwide. Now, I'll move now to donor characteristics, and here I'm going to move to last year experience. Our median age of the donors was 35, which falls in between, I guess, Europe and US. If you look at Europe, it's approaching almost a median age of 45. In the States, still it's around 28. If you look at the cause of death, you will find that last year we enjoyed having 57% of them were victims of trauma, and almost 30% of strokes or intracranial bleeds. And there were a fewer number of patients who suffered from either anoxia or other causes. Our utilization rate of donors last year was 34%, and again that matches what's reported in literature in the US, maybe slightly better or higher than Europe, with the exception of Spain. Now, if you look at the reasons for donor refusal, a majority of them were because of donor medical morbidities. The heart was not good. 5% family refusal. Donor death was about 8%. One of the challenges that we face is that we have donors that come from centers where there is no facilities for cardiac catheterization, and or, sometimes the catheterization would be resistant to do the cardiac cath, or if it's a multi-organ transplant, sometimes our colleagues from the renal transplant, they become worried about subjecting the donor for cardiac catheterization. Now, last year, out of 12 patients above the age of 40, we performed 67% of them without doing cardiac before surgery. Recipient characteristics, we generally have slightly higher number of patients with dilated myopathy compared with the rest of the world, and less of ischemic cardiomyopathies. On the pediatric side, one thing about the adult population also, we start to have increasing number of patients with adult congenital heart disease that are in need of heart transplantation. On the pediatric side, again, the majority of patients are dilated myopathy patients, with only 14% of patients with congenital heart disease. If you look at the age distribution over the years, you notice that we are now including older patients, older recipients. If you look at specifically the age between 40 to 59, it almost tripled compared with our experience in the past. Now, we still, overall, we have younger population compared with the Europe and the US. If you look at the blood group, although we do 41% of blood group O, if you look at our waiting list now, 2/3 of them are still blood group O. So which tells you that our population here has a very high rate of, high number of patients with O positive blood group. Now, 23% of our patients are bridged to transplant with an assist device, mainly HeartMate 2, and in the last 2 years has become HeartMate 3. Multi-organ transplant and retransplantation, we did 2 cases of heart-lung transplant, and we did 2 cases of heart-kidney transplants, and all are doing well, actually. Retransplantation, we did 2. One of them, she was retransplanted after 23 years of her first heart transplant. She developed severe coronary vasculopathy and subsequently underwent retransplantation. Heart transplantation process, we do on average about 70 to 80 heart transplant workups every year. If you look at the average waiting time for transplant is about 85 days. One of the challenges that we face that often that we have donors from outside Riyadh, which means that we have our procurement team has to travel to different parts of the kingdom, and with the constraints, time constraints, that puts our team at, it's quite challenging. Last year, 65% of the donors that were utilized were from outside Riyadh. After the transplant, if you look at our ischemia time, our average ischemia time is 226 minutes. Because as you know, as you move and your ischemia time goes higher, your outcome, it will be at the expense of outcome. Post-transplant, we utilize, for induction, we use globulin. For the rest, for maintenance, we use tacrolimus, Cellcept, and prednisone. In few number of patients, we use sirolimus, particularly patients who cannot tolerate it because of renal dysfunction. Outcome, if you look at the overall outcome, from the beginning of the program, from 1989 till now, till 2016, our 1 year survival was 83%, and a 5-year survival is 69%, 10-year survival of 52%. But this was affected by our early experience, and if you look at the next slide, that will show you the difference. When we were doing small number of patients, our 1 year experience and 5 were quite low. As we moved and the program became more active, our 1 year survival now is 87%, with a 5-year survival of 74%, and 11-year survival of 50%, which pretty much matches what reported by the International Society of Heart and Lung Transplantation. And this is another slide from the last ISHLT report that shows you if you are a program that does only 5 heart transplants, your hazard ratio for mortality, 1-year mortality, is almost two times the compared with if you're doing 20 and above. What about post-transplant? Working status post-transplant. Of course, we have higher rate of employment, but I think this reflects that we have younger population, 58% at 1 to 2 years, 62% at 3 to 4 years, and 71% at 5 years. So that basically reflects the younger population that we have. This success is a result of a teamwork, and I would like to conclude with this quote from Henry Ford: "Coming together is a beginning, keeping together is progress, working together is a success." Thank you very much.